Welcome, everybody, to this very first plenary session of day 3 of Rio. The focus is prolonged cardiac monitoring and transforming patient care with a 14-day continuous insights. And for this, we have case recorded with case operator Suneet Mittal from Valley Health System in New York. And we are also joined by our panelist, Patrick Badertscher from Basel, Switzerland. Welcome, both of you. And I think without any further delay, Suneet, I think you will take us through your case.
Julian, hello. Thank you for having me. And what I would actually like to take us through is a focus on the CAMELOT trial and the clinical implications of this study. So thank you to the meeting organizers for the opportunity to present today. So we all know that today there are many different types of ambulatory monitors that are being used in clinical practice. As you look at this slide, we've evolved quite a bit from the 12-lead electrocardiogram shown on the top left, or the standard leaded 12-lead Holter monitor showed in the top middle. Today, there's increasing use of smartphone-based applications like the one shown in the top right. Increasingly, we move to patch-based monitors that can provide longer-term Holter monitoring, mobile cardiovascular telemetry monitoring, even auto-triggered loop monitoring as shown in the slide below. We also see that there are increasing use of implantable loop recorders and even smartwatches. What has not really been known is the comparative efficacy of these different products. And the purpose of the CAMELOT study was to really look at whether there are differences between Holter monitoring, patch-based long-term Holter monitoring, event monitoring, and mobile cardiovascular telemetry monitoring. So CAMELOT was a large study. It was a retrospective cohort study using the Medicare fee-for-service sample, looking at inpatient and outpatient medical claims in the United States for a period ranging from January 1st, 2016 to December 31st of 2019. We included all Medicare beneficiaries, which by definition is greater than 65 years of age, without a preceding arrhythmia diagnosis. They were diagnosis naive, to investigate usage and clinical outcomes associated with these different strategies. And as you can see, we started with a cohort of 1.6 million people and ended with nearly 300 million people. Now, devices of interest included Holters, long-term continuous monitors, event monitors, and mobile cardiac telemetry monitors. Using the National Provider Identification Number, we could identify the manufacturer of these devices. We sought to see the diagnostic yield for the arrhythmias listed here, and we sought to evaluate the following 3 clinical endpoints: 90-day diagnostic yield, the 180-day retest need, and the annualized use of healthcare resources used in this cohort. So let me first show you the characteristics. At this time period, still a lot of Holter monitored use, but an increasing number of mobile cardiac telemetry units and long-term continuous monitors. Patients were similar in age. About 2/3 of the patients were female, and they had a Charlson comorbidity index ranging between 2.2 and 2.8. Now, this is the first outcome variable of the slide that was interesting. This is the probability of a diagnosis by one of these various technologies. And what you see is that the best diagnostic yield was related to long-term continuous monitor. And even within that, there were brand-specific differences. It should also be noted that mobile cardiac telemetry monitoring and standard 12-lead Holter monitoring had a much lower likelihood of diagnosis. And one of the surprise findings here was how much worse mobile cardiac telemetry was relative to Holter monitoring. Here's another endpoint: the likelihood of having to retest the patient within 180 days of initial ambulatory monitoring. Again, you see the same trend. the best outcomes with a single manufactured long-term continuous monitoring. And again, mobile cardiac telemetry monitoring continues to do worse. And again, brand differences in this particular endpoint. When we look at various variables of annualized healthcare resource utilization, in this busy slide, we looked at inpatient hospitalizations, emergency department visits, as well as outpatient visits. Again, trends to better outcomes with long-term continuous monitoring as opposed to the other technologies. Now, why these unexplained differences? Well, they may be related to differences in wear time that may be related to the comfort of various products, the adhesion, the compliance with patch changes, or the need for battery charging. Maybe there are differences in signal quality, or maybe there are differences in algorithms for arrhythmia detection. And maybe there are differences in data reporting and how robust the AI and algorithms are, the type and quality of data being presented, and maybe even the quality of overreads by ECG physicians. Now, interestingly, at the same time this study was being reported was this interesting study from the University of Pennsylvania, where they, in the same patient, had two different types of monitors implanted in AFib patients. Shown in the red is mobile cardiac telemetry, and shown in blue are standard patch-based Holter monitor. And you see that there were various differences with a higher diagnostic yield of detecting AT and AF in the long-term Holter group as opposed to the mobile telemetry group. And even in certain patients, vast differences where patients were in persistent AFib by one system being recorded as being in sinus by another system. So I want to conclude with these conclusions. In this large contemporary analysis of Medicare beneficiaries in the US receiving ambulatory monitoring, there were substantial variations in monitoring strategy. Long-term continuous monitoring or extended Holter was associated with the highest diagnostic yield. The choice of monitor impacted yield, need for repeat testing, and subsequent acute care hospitalization. And I think it's important to recognize that different monitoring strategies may produce different results with respect to these outcomes. So I'll turn the floor back to you, Julian. Thank you.
Wonderful. Thank you very much for this very interesting kickoff and also highlighting, let's say, different technical aspects of monitoring. Patrick, you, and from the Swiss perspective, you also have maybe, let's say, major opportunities how to follow up and how to monitor patients. What would be the preferred way of monitoring your arrhythmia patients in your clinical routine?
Hi, Julian. Hi, Suneet. Thank you for the invitation. So regarding the optimal monitoring strategy, I think it really depends on the setting, what you're looking at. So right now, for example, post-AFib ablation, we're still using regular Holter ECGs. We have identified different settings, and I will highlight that in my presentation later on, where we think there's an increased value for prolonged rhythm monitoring. For example, post-stroke, pre- and post-TAVI, and also in our arrhythmia clinic, depending on the frequency of the symptoms. As you said, in Basel or in Switzerland in general, we have the luxury situation that we can choose the optimal device for our patient. So I think it also depends on your healthcare system, which monitoring strategies you can use.
So, okay, now I hope we did not lose contact to you. I see a frozen monitor, but I hope we are still connected. Oh, wonderful. Okay. Suneet, also coming back to your presentation, also asking, looking into, let's say, technical difference and quality and the outcomes of what you monitor and the subsequent analyses, looking also into the field of ARRY, which, by the way, this term has been eliminated by the recent ESC guidelines, basically from our European perspective. But what is your impression with different, let's say, non-lead type of monitoring devices, and how do they compare to leads, and how do they compare to ARIA with your based on your experience and based on also, of course, on your study you presented on?
Yeah. Yeah, Julian. So let me just take a step back and say that, in our practice, when we're taking a patient with AFib, which is the most common scenario, we recommend to patients that everyone needs some rhythm monitoring strategy. And we discussed at great length, the value proposition of smartphone-based devices, smart watches, ambulatory external monitoring, and even implantable loop recorders. And for some people, of course, external monitoring is what they prefer. Now, within that cohort, I think for the reality is that patients really don't like leaded systems. And so we have really evolved to patch-based systems for all forms of monitoring, whether 1 to 2 days of Holter monitoring, for 3 to 4 days of extended Holter monitoring, or even 30 days of mobile cardiovascular telemetry monitoring. Within that cohort, though, I think what CAMELOT really tells us is that we really should gravitate to long-term continuous Holter monitoring, because it appears that the data are more robust in that cohort. And in my AFib patients, that's the kind of technology that I'm using routinely now.
Wonderful. Thank you. Wonderful. And I think this is a good moment now to kick off for our second presentation. And Patrick, I think you already also have prepared a couple of slides. And then, of course, we will rediscuss together again.
So I was asked to talk about our clinical experience, real-world applications, and learnings. So when we got the opportunity to use long-term continuous monitoring at the University Hospital in Basel, we identified 3 settings where we wanted to use them. We wanted to risk stratify our patients undergoing TAVR, pre and post, using a 40-day ECG monitoring. We used it in our arrhythmia clinic with patients presenting with palpitations. And we started using it in all patients post-stroke for detection of atrial fibrillation. I'm going to highlight our project regarding the monitoring pre and post-TAVI. We conducted this ERA survey 2 years ago, where we asked centers in Europe, how are you risk stratifying your patients with left bundle branch block after TAVI? And I know that Suneet just co-authored a recent consensus document regarding this topic, so I'm very interested in his opinion later on. And our survey revealed a large heterogeneity of different practices. And so we thought this would be a very interesting patient population to study. So far, we already studied 120 patients pre and post TAVI. These are the results from the first 24 patients. You can see that the median age of these patients was 82 years old, 53% were female. And even though it was an elderly population, the median wear time in this population was over 12 days. So this just highlights the ease of use of this monitoring device. You can see on this slide the pathological findings pre and post TAVI. We found high degree AV block in 4 patients. And in 2 cases, this led to a pacemaker implantation at 11 and 12 days post-TAVI. What about stroke? The search of atrial fibrillation is debated after patients with an ischemic stroke. We are trying now to evaluate if a biomarker-guided strategy has an enhanced value, meaning we stratify the patients post-stroke according to their MR pro AMP level, and all of them receive an ECG patch, and we compare it to the previous phase where we mainly used Holter ECGs or implantable loop recorders. The primary endpoint is detection of atrial fibrillation and prescription of oral anticoagulation, and we will start enrolling in January. What about diagnostic efficiency and costs? And this is another analysis from Medicare beneficiaries. This was an analysis of almost 300,000 patients. 10% received an ambulatory event monitor, 54% a Holter monitor, long-term continuous monitoring in 13.3%, and mobile cardiac telemetry in 23%. On the left side, you saw that the odds of retesting within 180 days was the lowest with long-term continuous monitoring, highlighting a high diagnostic efficiency. On the right side, you see healthcare utilization. You see in blue the baseline costs, and in gray the follow-up costs of patients undergoing prolonged rhythm monitoring. And you can see that the annual costs the following year was the lowest for long-term continuous monitoring compared to the other devices. So in summary, regarding our real-world experience, long-term continuous monitoring offered the possibility for novel patient pathways. We saw an improved patient compliance and ease of use. There was a high diagnostic yield resulting in a high diagnostic efficiency. And the health resources impact depends on your healthcare system, and further data is needed. And now I'm looking forward to the discussion.
Yeah, wonderful. Thank you, Patrick. So pretty much, echoing, also mirroring some of the US experience as well. When it comes to the or the high quality or the high adherence of wearing this monitoring device, what do you think is one of the key differences as compared to maybe my standard Holter EKG?
Well, I think that it is
your best
definitely, Julian, I definitely think that patch-based systems have become, better and better. They're becoming lighter, thinner. Patients are able to get into the water and shower. They are easily hidden beyond their usual clothes. And so what I do find is that at least in the acceptance of traditional lead-based Holters is really low in U.S. patients, to the point that as our existing Holters become obsolete, we are not replacing them with new leaded Holters. We're simply gravitating to patch-based systems. I believe here the patients have spoken, and we are, listening to, what they find most tolerable, especially as you extend the recording duration out from 1, 2, and 3 days to 1, 2, 3, and 4 weeks.
Right. Patrick, any additional thoughts on this?
We noted 2 additional findings. One, most of the patient that had a patch ECG, and then they come back and then you propose them, let's do now a Holter ECG. They don't want the Holter ECG anymore. They want to stay with the patch ECG. And 2, there's also some slight differences between the different patch ECG systems. We noted that the ease of use or the compliance is the highest. It is if it's a product, a hole-in-one, meaning there's no separate battery or the patient is not involved in charging the battery. If it's just a solution that you could put on and take away again in 14 days, showed with, in our experience, the highest compliance rate.
Right. Thank you. Maybe one question for both of you, but also, of course, both of us or all of us in our daily life. It is after AF ablation, for instance, there's recently, the option trial which has been published, and option trial was associated with a very, encouraging low stroke rate in both arms after AF ablation. But still, we adhere to, of course, our recommendations to prescribe oral or to continue oral anticoagulation according to the CHA2DS2-VAS score. So do you think, let's say, a new paradigm in monitoring may lead or may impact the future role of anticoagulation after AF ablation? And where do you see potential with, for instance, continuous monitoring devices? Patrick, start with you.
It's a great question, and I couldn't agree more. I mean, when you look at the option trial, among these 1,600 patients, the rate of disabling stroke was only achieved in 0.3%. Actually, only 2 patients among the 1,600 suffered from a disabling stroke. So, and this finding has been mirrored by like recent studies, for example, Artesia or NOAA with very, very low stroke rates. So I completely agree with you that probably the risk is much lower than it used to be. And it could even be that in 20 years from now, we will think, why did we anticoagulate all these patients after successful AFib ablation for such a long time? So definitely with continuous monitoring, we would gain more insights also post-ablation regarding if it's AF burden that is most important or new risk score that we only need to probably, we only need to anticoagulate a subset of patients that really benefit. And it's now our task to identify these patients.
Yeah, Julian, I agree with Patrick, and I also remind the audience of 2 ongoing clinical trials that I think will also add here. So one is, of course, Atul Verma's OCEAN trial, looking to see what the role of transitioning people, off of rivaroxaban, to aspirin could be in people who apparently have had a successful catheter ablation procedure. So that will give us some information. A subset of these patients have implantable loop recorders, so we'll know. And then Dr. Rod Passman's REACT AFib study, which is looking at the role of a smartwatch guided pill in the pocket approach to anticoagulation, with a similar thought that, let's try to reduce the overall exposure to oral anticoagulants in this type of patient population. So I think that we are all in agreement that it's hard to tell a patient that lifelong anticoagulation is necessary when we have technology to know that the ablation is objectively successful. And I think the next few years will almost certainly help us change that paradigm.
Right. But still, we are all facing the general problem of not having a very clear threshold of, for instance, AF burden, which is a clear link to the stroke risk. And so therefore, I think there's still a lot of more data and studies we need to work on in the future. Another topic, and switching a little bit the type of arrhythmia, is in our clinical routine and practice, we are often, of course, are exposed to patients with a lot of premature ventricular contractions, for instance, and we quantify with an Holter ECG. At one point in time, it's got 15,000. The next day, it will be completely almost vanished. So where do you see maybe the role also for continuous monitoring for those group of patients? Suneet, we start with you and then Patrick.
Yeah. So I think that continuous monitoring is very helpful in that cohort. Julian, as you said, we historically were basing everything on 24-hour Holter data on patients, and then we recognized the day-to-day variability. It's our practice now to try to monitor patients like that for no less than 7 days, but up to 14 days to try to get to that issue as to how much variability is. Also gives us information about whether these PVCs tend to be more nocturnal or during the day, more at rest or with exercise. And you can also, recognizing that you only have a single lead, but you can start to get some information about whether this ectopy is unifocal or multifocal, and that can also help guide clinical decision making. So I think that these monitors do have a role, in the management of patients with frequent ventricular ectopy.
Right. Comment from Patrick, or?
Yes, I completely agree with Suneet. There was actually a hard-written paper regarding this topic showing that a 40-day ECG patch monitor in patients with PVC, you can have a variability from the PVC burden in these 14 days from 3 to 24%. So this is whatever I'm wondering when you perform a catheter ablation of PVC and then you have a burden of 23% and you monitor it with 24-hour Holter ECGs, and after ablation it's 11%, and then you say, well, at least we achieved a burden reduction. So I'm always wondering if there's really a burden reduction or it was just a variability of the PVCs. What would be great with this continuous monitoring, it's a single lead ECG, but now we have AI, deep learning. So maybe we can use some AI to already get some information from a single lead ECG regarding the origin of the PVC, because this would also help to guide our patient, if it's a simple REOT or if it's looking more like not an idiopathic PVC.
Very good. Very good thoughts. And but coming back again to, let's say, our daily life and clinical routine in Switzerland, where do you use and how do you use in your, and this is kind of my initial question to you, how do you use continuous monitoring in your daily practice? And what is your top 2 or top 3, let's say, such scenarios?
So as I already highlighted, we use it post-TAVI. We use it in stroke patients. We still go for Holter monitors post-AF ablation. This might change in the future. Actually, for patients with infrequent palpitation suspected for PSVT, I think there's a great role for smart devices, smartwatches, or something similar. And otherwise, I really depend on the frequency of symptoms in the arrhythmia clinic deciding for the right tool. Regarding implantable loop recorders, we saw in our centers that we didn't implant that many loop recorders anymore because we have the advent of the smart devices and the patch ECGs. So I think the role of the loop recorder probably in the future has to be redefined.
Yeah, that's a good point.
Yeah, Julian, I agree completely.
Suneet, I thought you wanted to comment. No, yeah.
Yeah. Now, the most common causes, the use case scenarios is exactly what he's highlighted. Frequent syncope, potentially the post-TAVR patient, the post-cryptogenic stroke patient. But in the AF population, I do think it's important for us to always keep in mind the consensus document still states that in patients with persistent atrial fibrillation, some form of Holter monitoring is recommended at the 6 and 12-month mark, even in a patient with paroxysmal atrial fibrillation, at the 1-year mark. So there are, consensus guidelines on when this monitoring should be done. We balance costs with practicality, but I still think that these monitors are going to be here for the long haul.
Yeah, wonderful. Yeah, thank you, guys. I think that was a very, very interesting and very informative session. And we are, in fact, facing also here a new chapter, basically, of monitoring. It's not only in ablation, but it's also in monitoring. We have novel developments, and therefore, I think one of you mentioned it, the number of loop recorder implantations. I think, Patrick, you mentioned this, and so in your institution, in your experience, went down. So I am very much looking forward how this may, in fact, impact the clinical routine in the future. For me, I need to thank both of you for contributing, excellent presentations, great discussions, and I wish everyone another very successful Rio day for today. And I think for me, it's time to head over to our next session. Thank you very much, guys, and see you soon.